Alright, let's cook. This is long awaited. We're going to be drinking water throughout this. This is our final lecture in Psych 201 on psychological disorders. So last time we went over personality. Now we're going over psychological disorders, right? These have a lot of interplay because generally, as we'll see here, psychological disorders are almost entirely characterized by extreme versions of our base, big five personality traits, right? That's a really simple way of looking at it. But just like last time, because there's so much content to cover here, we're going to split this into sorry about that noise. We're going to split this into a handful of sections as opposed to kind of going through everything one after another, right? So we'll look at understanding psychological disorders, understanding the approaches to psychological disorders, mood disorders, the schizophrenia spectrum and psychotic disorders, personality disorders, anxiety disorders, obsessive compulsive and related disorders, trauma and dissociative personality disorders, and a couple of additional concepts. Okay, so first and foremost, understanding psychological disorders, right? So, what are psychological disorders? Psychological disorders are essentially patterns of behavior or psychological symptoms that impact multiple different areas of life, right? They're associated with distress, impaired function. We see different positive and negative symptoms, which we will look at later. You'll understand what that means. Anyway, this chapter, as I said, will be exploring different categories, emphasizing classification, symptoms, different dimensional values, and dimensional versus categorical approaches even to diagnosis, right? So just a little look here, right? We have things like anxiety disorders, dissociative disorders, mood, personality, psychotic disorders. Yeah, we'll be looking at different ones of these. All right, understanding the approaches to psychological disorders. So first, we have the dimensional approach to psychopathology. So essentially what this says is all psychological traits are behaviors that exist on a continuum. For example, sadness is the lighter version of depression. Anxiety is the lighter version of a panic disorder. Most disorders, as we said before, through this dimensional approach, reflect extreme expressions of normal personality traits along this continuum, and this continuum typically reflects the Big Five model, right? So as we see here, we're looking at like things like openness, extroversion, agreeableness, consciousness, and neuroticism. Those big five traits and the score along that continuum, right? Yeah, a dimensional approach typically is useful in understanding nuance and variability across individuals, specifically here, right, when we're looking at these, the extreme nature of some of these personality traits. Yeah, all right, we can look at the big five traits on a continuum, and we can kind of assemble a personality profile of an individual, right? Are they very high in agreeableness? Are they very low? Are they very high in openness? Are they not? And we can assemble this personality profile along these continuums to understand how they might deviate in different disordered kind of states, right? And say you're very low in conscientiousness, so this is going to happen. You're very high in openness, so this is how you're going to react to, a different disordered state. Spectrum disorders, right? Some disorders that exist on a spectrum, like we were saying, right, on a continuum, rather than as discrete entities, are some below. So naturally, there are some disorders that exist as discrete entities. For example, like PTSD, as opposed to, for example, something like autism, right? That's what we're looking at here, along with things like schizophrenia, which we'll get into, and mood spectrum disorders, right? Just to go over those two. Mood spectrum disorders typically seen as going from like sadness to dysthymia, which we'll get into, to major depression, to bipolarism. Schizophrenia, right? We're looking at magical thinking, which typically turns into schizotypal traits, and that turns into schizophrenia. But most importantly, autism. The autism spectrum disorder, right? It includes various different levels of social and communication deficits and behavioral rigidities. While we consider autism generally to be on a linear spectrum of 1, 2, and 3, in respective order for severity, now we typically consider it to be non-linear, right? We consider tons of different variables, such as, depression, aggression, social skills, eye contact, tics, noise sensitivity, whatever it may be, when we're evaluating these people, right? We determine if their autism spectrum symptoms are high or low, and then we prescribe assistance to that accordingly. Yeah, as opposed to just simply seeing it spectrumistically, I guess. So, how do we differentiate between normal and abnormal functioning? Right, so when we're looking at things on a continuum, how do we differentiate between the mild form of a thing and the severe form of a thing, right? Sad versus clinically depressed, anxious versus a panic disorder, introverted versus having schizoid personality. Uh, you know, um, Continuums can help us get a black and white sense of the difference between our normal processes and abnormal functions. However, effectively diagnosing the disorders listed on the severe side that we talked about requires something a little bit more practical than the dimensional approach to psychology. Because typically seeing things on a continuum doesn't really get us everywhere we want, especially with raw differentiation and determination. So what's the solution to that, right? It is the categorical approach to psychopathology, that of which is primarily demonstrated within the DSM-5. So the categorical approach, again, I think we might have gone through this in personality. I guess we did not. Yeah, the categorical approach, as opposed to the dimensional approach being mostly spectrumistic, the categorical approach has, it's based on symptoms in clusters, right? Symptom clusters that meet specific diagnosis criteria. Categorical thinking simplifies communication, right? Saying either someone has something or does not have a symptom, and from that point we can work towards actually establishing whether they do or don't have the disorder, right? We're looking at these symptoms and the have-nots or the haves as a cluster. Clinicians generally prefer this method, right, because it's more useful for real-world practicality. And generally, the human mind prefers to think in terms of categories and the presence or absence of symptoms and disorders, as opposed to thinking along a continuum. So, for example, again, when it came to autism, we broke that up into different categories rather than umbrellaing all of it and establishing different levels. Just a quick note, what is the DSM-5? The DSM-5 is the Diagnostic and Statistics Manual of Mental Disorders. It is the official manual published by the American Psychiatric Association. So that is understanding the approaches to psychological disorders and understanding psychological disorders generally. Now finally we're going to get into mood disorders. So mood disorders, right? We can understand this in terms of things like mania, different bipolar symptoms, depression, hypomania, and we're going to get into all of this, right? So before we get into it, right? Actually, as we get into it, let's classify first. Unipolar versus bipolar. Unipolar is essentially saying that along this emotional continuum or this functional continuum, right, based on kind of mood regulation, what you have essentially leads to you being unipolar on one side of this thing, right? You only have the sad symptoms, for example, versus bipolar, you can have some of each. So with this, right, we're going to look at this. We're going to look at this more on these different words that I'm going to say. But essentially, you have the euthymia level right in the middle, and to the left and right of that is just generally being sad and happy. This is our normal people. Then, to the left of being sad, you have things like mild depression, severe depression, and suicide or psychosis. That severe depression and suicide or psychosis is the loss of function area on the left side. On the right side, we have things like hypomania, mania, and mania and psychosis, which is our general loss of function range. Dysthymia and dysthymia is it is seen as unipolar, right? You have euthymia and some sad symptoms. You're more on the left side. We also have major depressive disorder. That is unipolar, right? It's all on the left side. It's all the depressing based symptoms. But then we have things like cyclothymia. That typically sits in the middle, right? It's bipolar. We have type 2 bipolar and we have type 1 bipolar. We're going to get into all of this. So first, we mentioned mania. Remember, mania is in the far right side of this kind of like emotional spectrum that we had looked at when establishing unipolar versus bipolar. Mania was on the far right side. we got to understand this because mania plays a lot. It is a huge role in bipolarism. Again, mania is a hallmark in bipolar, but you can be manic, you can have mania without having BPD. Right. So according to the DSM-5, mania is a period of abnormally and persistently elevated or irritable mood, an abnormality and persistently increased goal-directed activity or energy, lasting at least 1 week and present most of the day, nearly every day. So you are essentially insanely energetic, insanely happy in abnormal levels. You can also be quite irritable and quite elevated with your mood. You can be talkative. We'll talk about some of these symptoms here, but essentially during this period, 3 or more of the symptoms I'm about to list, or 4 if the mood is only irritable and not seeing an increase in energy. 3 or 4 of these symptoms are present to a significant degree and represent a clear change from levels of respective usual behavior. So those symptoms are inflated self-esteem, decreased need for sleep, talkativeness, increase in goal-directed activity or psychomotor agitation like purposelessness or again, higher goal-directed activity in like work or school. Flight of ideas, right? So your thoughts are racing. Distractibility, right? You're easily distracted or you're taking more risky behaviors. 3 or 4, if you're only irritable and you don't have more energy, of these symptoms classify mania. A case we looked at, essentially, a kid was skipping school to work on a project that he says will save the world. He's incredibly enthusiastic about it, all the way to the point of exaggeration. His train of thought is completely random and incredibly difficult to follow, though he seems to have an incredible energy about him and is consistently making plans and details of how to save the world. His friends can't tolerate him. Clearly, he meets the diagnostic criteria. Eventually, he's going to collapse and run out of energy. It's a manic episode, not a bipolar episode, because again, he exhibits mania without depression, right? Bipolar, you need some of these right side symptoms that are all like happier, more energetic, up until manic, and some of these left side symptoms, which are sad, up until depressed, up until, suicidal, right? So, we understand mania. Now, let's look at unipolar mood disorders, right? Mood disorders where only a depressive symptom is present, these left side symptoms, if we remember right, these sadder depressive symptoms. So, a unipolar mood disorder, as we discussed, we have major depressive disorder, or MDD. What is MDD? MDD is intense sadness, hopelessness, loss of interest, fatigue, and disturbed sleep and appetite. It can last at least 2 weeks, and it sees significant impairment in daily functioning. So what are some of these diagnostic criteria, right? So if we see 5 or more out of the 9, including 1 and 2, of the following symptoms in the same 2-week period, with those symptoms being a depressed mood, or being more irritable, right? A loss of interest or pleasure in most daily activities, change of weight and appetite, insomnia or hypersomnia, psychomotor agitation or retardation, loss of energy or fatigue, inappropriate guilt or sense of worthlessness, thoughts of death, impaired concentration, then we see that diagnosis, right? These symptoms can cause a lot of distress and impairment, right? An MDD episode is not attributable to substances or medical conditions. We can see the diagnosis if the episode is not better explained by a psychotic disorder as opposed to MDD. And we can see this diagnosis if the patient has not had a previous manic or hypomanic episode. So again, MDD, intense sadness, hopelessness, loss of interest, fatigue, none of these right side manic symptoms, right? It's unipolar. Dysthymia, remember we talked about that. It's another unipolar disorder. It is persistent depressive disorder. Essentially, it is a less severe form than major depressive disorder, but it lasts longer. It can last for longer than 2 years. It is symptomized by chronic low mood, fatigue, poor self-esteem, and hopelessness. Right here we have a graph. We're looking at where dysthymia is versus where MDD is. So when we're looking at MDD, you have your normal mood. and very quickly you can become extremely depressed, but then it'll level out slowly and get back to your normal range in a faster amount of time versus with PDD or P. Diddy or persistent depressive disorder or dysthymia. It'll go down and then it'll stay down for a while. Finally, again, our unipolar disorders, we've gone through MDD and dysthymia. Now we have seasonal affective disorder. Essentially, it is depression that follows a seasonal pattern. It's usually winter for most people, and it's possibly linked to a lack of sunlight exposure. Those are our unipolar disorders. Now we have our bipolar disorders. Bipolarism, as we had looked at, is characterized by having both depressive symptoms and manic symptoms, right? Or those left side and those right side symptoms, those sad symptoms and their happy symptoms. And bipolarism is characterized by an alteration between these depressive and manic or hypomanic states. We'll define hypomania, don't worry. So, within these bipolar disorders, we have three. We have bipolar disorder 1, bipolar type 1, bipolar disorder 2, or bipolar type 2, and we have cyclothymic disorder, right? We'll get into these. So, bipolar 1. This is defined by full manic episodes with a major depression before or after. So essentially, it is a pendulum swing, right? A pendulum is big here with bipolar 1. You can swing from depressed to mania in a blink, right? It is a manic episode right after a depression episode. Or the other way around, right? A depressive episode followed by a manic episode, right? Swinging from one side to the other. A case that we looked at for this was a 20-year-old musician who went to his physician saying he's feeling depressed and unable to practice, right? He wants help, he wants drugs. However, afterwards he has turned into the opposite. He starts acting completely differently, and his pattern takes him back to the doctor with many complaints. His partner takes him back to the doctor with many complaints. She says that she doesn't want to crush him, but he's trying to book tours with the Rolling Stones. He shows things like grandiosity, erratic behavior, and delusions of grandeur while feeling better than ever. So this is clearly a huge depressive episode followed by an almost instant manic episode. Right? So again, bipolar 1, we're looking at that huge pendulum swing. Bipolar 2. Bipolar 2 is characterized by hypomania, right? It's hypomanic episodes with major depression before or after. Essentially, hypomania is essentially a more mild form of mania. It's not full mania yet. So people with bipolar 2 may experience less extreme mood elevations, and this is what hypomania is, right? It's less extreme than mania. These episodes are characterized by heightened creativity and productivity that are enjoyable and rewarding because their energy isn't as high. They don't have as extreme and sporadic symptoms. Bipolar 2 usually does not cause significant impairment to daily living, and hospitalization is not required. So again, it is much more mild than bipolar 1. That's important to keep in mind, right? Bipolar 2, much more mild, characterized by depressive episodes as well as hypomania, so kind of just less severe symptoms. And we see that when we look up here, back at that graph from before. Again, you still have major depression, still to the same degree as bipolar 1, but you don't have full mania. You have hypomania. You have not experienced a loss of function as you can with full mania. And finally, our final bipolar mood disorder is bipolar mood disorder is cyclothymic disorder. This is characterized by episodes consisting of hypomania and depressive symptoms that do not meet the full criteria for bipolar 1 or 2 or major depressive disorder, though being considered part of the bipolar diagnosis tree. Furthermore, its manifestations come onset in early life, and they are demonstratable via temperamental mood reactivity and dysregulation. So, essentially, we have bipolar 1, which can take you full pendulum swing all the way from major depressive to like almost not being able to function manic. Bipolar 2, you still have major depression, but you have hypomania, you're not asthmatic, and cyclothymic disorder, you're not necessarily majorly depressed, and you don't have full mania. You have episodes of hypomania, and some depressive symptoms, but not fully. These are our, our unipolar and our bipolar mood disorders under the mood disorders umbrella. So finally, schizophrenia, the big thing that everyone always talks about these days, right? Let's get into that. So, the schizo spectrum. Let's look into this really quickly. Essentially, just a first note. Other than schizophreniform, which we'll talk about, everything in schizophrenia, everything along the schizophrenic spectrum, the number of letters in the disorder correlates with the number of symptoms. So, for example, first we have schizoid, which is essentially just a very introverted personality and voluntarily withdrawing from social interactions. Then we have schizotypical, which is a few more letters than schizoid, which has schizoid symptoms plus magically thinking or odd behaviors / positive symptoms. We'll talk about that. It doesn't mean good. Essentially, positive symptoms are just excessive functions and compared to normal ones. But we'll talk about this, right? So again, schizoid, very introverted, voluntary withdrawal. Schizotypical, you have those schizoid symptoms of being very introverted and voluntarily withdrawing, plus magical thinking, odd behavior, and other positive symptoms. Then you have schizophrenia, which sees schizotypal plus psychosis. With psychosis, if we remember that definition, if we've talked about it before, meaning disconnect from reality, right? Then we have schizoaffective. Again, a few more letters than schizophrenia. We have all the symptoms of schizophrenia plus an additional mood disorder on top of that. And then we have schizophreniform, which we talked about. Again, it doesn't really fit into this because its symptoms are lesser. It's schizophrenia, but symptoms are only for 1 to 6 months, right? So again, schizospectrum, we have schizoid, schizotypal, schizophrenia, schizoaffective, and then schizophreniform, even though that doesn't really fit into it. Schizophrenia and positive and negative symptoms. Positive and negative symptoms apply to all personality disorders, but we're using schizophrenia as kind of like a conduit of looking at this, right? So, schizophrenia is a chronic psychotic disorder with disruptions in thought, perception, emotion, and behavior. It's typically diagnosed in late adolescence or early adulthood. It, as well as other personality disorders, as I mentioned, have both positive, which again doesn't mean good, and negative symptoms. Positive symptoms are the presence of problematic behaviors. Negative symptoms are the absence of normal functioning. Alternatively, positive symptoms again are excess functions. While negative symptoms are deficits in normal functioning, right? So we'll get into this, right? Positive symptoms in schizophrenia. Delusions, right? We have delusions, hallucinations, disorganized speech, disorganized behavior, and bizarre behavior. So delusions, right? These are things like, persecutory delusions, right? The belief that others are persecuting you. Referential delusions, right? Believing that objects and events and other people have particular significance to you. More so than the average person. We have grandiose delusions, right? Belief that you have higher power, knowledge, or talent. Identity delusions, guilt, control. All these excessive normal functions / problematic behaviors. Hallucinations, right? These are sensory experiences. They don't just have to be visual. They can be, it can be any of your senses, right? You can feel like someone's touching you. It can be you hear something that's not actually there. These are all hallucinations. Additionally, with positive symptoms, people may think, despite counter evidence, that they have a terrible disease, that they're being talked about, that they're being mind controlled, or being cheated on through several different delusions, such as ill health, reference, thought control. These positive symptoms, not fun. Negative symptoms, right? These are things like having no emotional expression, poverty of speech, right? Loss of motivation, the inability to feel pleasure, social withdrawal. Think of it as positive symptoms take you to extreme versions think of it like a number scale, right? Where you have your 0, which is your average personality trait, your average way of being. Positive traits take that all the way up to 10, right? They're kind of adding and taking these things into their extremes, while on the negatives you have them being taken away from, in a way. Now, how do we diagnose schizophrenia? According to the DSM-5, 2 or more of the following symptoms must be present for at least 1 month. Again, the length of these symptoms can be less if schizophrenia is treated successfully. But again, 2 or more of the following symptoms present for at least a month, and at least 1 symptom must be hallucination, delusion, or disorganized speech. So the symptoms are hallucination, delusion, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms such as affective flattering, alogia, avoliation, whatever it is. You must have 2 or more of these symptoms, with 1 being hallucination, delusions, or organized speech. Additional criterion include continuous disturbance for 6 months and social or occupational dysfunction for long amounts of time. Family markers are also important. They're a good tell for schizophrenia, right? Statistically, the more close someone is genetically related to a person with schizophrenia, the greater the risk that they will develop it. So it's unfortunate. Okay. So, just to go over what we've gone through again, we talked about understanding psychological disorders and their general definition. We talked about the approaches to psychological disorders with the dimensional and categorical approaches, right? Kind of picking out these symptoms, have-nots or haves, versus like it being a continuum. We talked about mood disorders, right? Bipolarism, unipolarism, and we talked about schizophrenia, their spectrum, and psychotic disorders. Positive, negative symptoms. Okay. Now, let's get into personality disorders, okay? So, we got quite a bit to cover here. This is our first really big meat and potatoes section. You can consider everything that we've done up until this point to kind of be like a conceptual prepping for what we're going to get into, right? So, buckle in. Let's get a sip of water. We're hitting that 30-minute mark, and we are on pace for what will probably be an hour and a bit lecture. So, personality disorders. What are they? Personality disorders are groups of disorders that are characterized by rigid, maladaptive traits that can cause great distress or the inability to get along with others. They're enduring patterns of thinking, feeling, and behaving that deviate from expectations, right? Some of the traits for this, right, they can be early onset, showing some evidence in their existence, at least in late adolescence. They can become stabilized over time. Right, where there's no significant period where these things are not evident, but not a lot of significant periods where they spike. They can be pervasive across a bunch of different settings, right? Different personal, social, and occupational situations. You can all see these personality disorders, and they are clinically significant amounts of distress or impairment that result in personal distress or impairment in social and occupational functioning, right? So personality disorders, not good, unfortunate, right? Disorders characterized by rigid maladaptive traits, causing a lot of distress and shit. So, we're going to look at a few personality disorder clusters, right, through kind of the categorical approach lens. So we have cluster A, cluster B, and cluster C, with cluster A being odd or eccentric disorders, B being dramatic or emotional or erratic disorders, and C being anxious or fearful disorders, right? We'll get into a dimensional approach to psychological disorders, but again, categorical approach just works way better for psychological analysis like this, right? So, Cluster A. Let's get into some of these, right? These are groups of disorders characterized by odd or eccentric behaviors. So within it, we have paranoia, right? Paranoid personality disorder. We have schizoid personality disorder, and we have schizotypal personality disorder. We'll get into these one by one. So paranoid personality disorder, again, it is a cluster A, odd or eccentric personality disorder. It is characterized by distrust, suspiciousness, belief others are exploiting you, or the belief that others are motivated to harm you. What are some of their symptoms? You can use the acronym GET FACT in order to remember this, right? So, paranoid people hold grudges for a while. They expect exploitation from others without sufficient biases. They don't really trust people. They think their partners are cheating on them. They think people are always attacking their character. They don't really trust and confide in a lot of people. And they read a lot of threatening meaning into things that happen around them. It's important to note that paranoia doesn't have any negative symptoms, right? Any of these lack of normal functioning. They only have positive symptoms, right? This excessive functioning. Next, schizoid personality disorder, right? Schizoid personality disorder is not like schizophrenia. Again, schizoid personality disorder is emotional coldness, detachment, no desire for social relationships to the point of voluntary withdrawal. Again, another acronym for schizoid symptoms, we have SIR-SAFE. A solitary lifestyle, indifference to praise or criticism. That's important. Again, they are not sensitive to criticism. Avoidant personality disorders, which we will get into later, is sensitive to criticism. We will talk about that, right? Just remember it. Again, more for schizoid, right? Solitary lifestyle, indifference to praise or criticism. Relationships aren't really of interest to them. They don't really care about sexual experiences. They don't really enjoy many activities. They don't really have too many friends, and they're emotionally cold or detached. These are some of the symptoms of a schizoid personality disorder, which again is an odd or eccentric cluster A personality, right? Especially focusing on the odd here. Then we have schizotypal personality disorder. Fitting, the acronym for this is Flat Earth. Why? Because these people usually have fantastical, magical, and/or odd beliefs and thinking. They don't really have many close friends due to interpersonal awkwardness and odd speech. Their appearance is usually eccentric or particular, or peculiar, right? They have the tendency to withdraw socially. They're excessively paranoid about different things and suspicious. They have abnormal perceptual experiences. They have the tendency to, think in conspiracies, are sometimes hostile. They think magically. They have odd speech, unusual behavior, and social anxiety. These are your schizotypal people. That is our cluster A section. Now, just a little thing to look at here. We have a grouping schema for different personality disorders. We're looking at it for cluster A, but it's not specifically for it. Essentially, we break down a person's positive symptoms, right, their abnormal behaviors, and their negative symptoms or their absence of normal functioning, and we designate a list of possible options that fit at least one category, positive or negative as such. Subsequently, we'd eliminate options if symptoms generally don't match, and we'd cement an option assuming both positive and negative match, right? So again, in this example, we looked at some positive symptoms for a person. We're looking at magical thinking, perceptual distortion. Paranoid doesn't really have that, even though we say yeah, but it doesn't really have that. Schizoid doesn't really have that. Schizotypal does, right? That magical thinking. The negative symptoms we're looking at social isolation, poor rapport, and constricted affect. Paranoid, right? Paranoid doesn't necessarily have social isolation. Schizoid does, but again, schizoid doesn't have those positive symptoms, so we can't say yeah, but schizotypal does have these negative symptoms, right? Social isolation, poor rapport. So it is both the positive and the negative. It's likely that this person does have schizotypal personality disorder. Those are our cluster A's. Let's get into cluster B. Cluster B personality disorders are more dramatic, emotional, and erratic. This is when we're going to get into things that you've heard of before, like BPD, narcissism. So, cluster B is a group of disorders characterized by dramatic, emotional, or erratic behaviors. Number one, we have antisocial personality disorder. This is the inability to respect the rights of others, what did I write? Sorry. There we go. Just need a nice little semicolon. Antisocial personality disorder. It is a cluster B personality disorder, characterized by dramatic, emotional, and erratic behaviors. Antisocial personality disorder. It is the inability to respect the rights of others. Irresponsible or unlawful behavior that violates social norms are seen as well. Psychopaths typically have antisocial personality disorder, but not everyone with antisocial personality disorder is a psychopath. That's important to remember. Psychopathy, or the psychopathic personality, as we're talking about psychopaths, is a personal construct characterized by impaired empathy and remorse, along with egocentric traits often masked by superficial charm and immunity to stress, which create an outward appearance of apparent normalcy. Again, APD doesn't really have this mask, this normalcy. It is the inability to respect the rights of others and irresponsible or unlawful behavior violating social norms. They're not putting on an outward appearance of apparent normalcy. But most psychopaths have APD. They just block out some of the pieces of APD by the use of psychopathy, right? Yeah. So APD, that's one of our cluster Bs. BPD. BPD is also one of our cluster Bs. BPD is characterized by intense and unstable emotions and personal relationships, chronic anger, fear of being abandoned, fear of loneliness, self-harm, and black and white thinking. People with bipolar personality disorder commonly experience a painful loneliness, motivating them to search for ways to fill up their holes, usually by any means necessary. So, borderline also has a lot of reaction formation, which we talked about in personality, where an individual essentially unconsciously replaces an unacceptable thought, feeling, or impulse with its opposite. Unacceptable being subjective, often in an exaggerated way to mask the true underlying emotion. In a simple way, like we talked about, this can be, someone in school having a crush on someone but presenting that they hate them. But in extreme ways, this can present itself in the form of, I hate you in a fight, when in reality they don't want you to leave and they really, really love you. But they present themselves in I hate yous. People with BPD can exhibit black and white thinking, which is different from the black and white treatment that narcissism displays, right, with the ways that they treat people. We'll talk about that. Here, this black and white thinking kind of presents itself in a form of irrational and absolute perspectives, where one thing can either mean or someone can either choose something or the other, that of which has no in between, and typically there is no right answer. This is usually manifested in arguments and kind of high stress conversations. So BPD sucks. Sometimes sucks to be around. Intense, unstable emotions, black and white thinking, fear of loneliness, self-harm, fear of being abandoned. The DSM-5 sets aside a particular diagnostic criteria for BPD, saying that BPD is a pervasive pattern of instability of interpersonal relationships, self-image and effects, and marked impulsivity, beginning in early adulthood, and presents in a variety of contexts, as indicated by 5 or more of the following. Frantic efforts to avoid real or imagined abandonment, a pattern of unstable or intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation, identity disturbance, which is markedly and persistently unstable self-image, impulsivity in 2 different areas that are damaging, right? Sex, binge eating, reckless driving, whatever it may be, recurring suicidal behavior, threatening against the self, affective instability due to the marked reactivity of mood, chronic feelings of emptiness, inappropriateness, anger, difficult managing emotions, transient stress-related paranoia. These are all BPD symptoms, right? I think we have a good understanding of it now. Another cluster B personality, we have histrionic personality disorder. So histrionic personality disorder is excessively displayed in women, while narcissism is generally and predominantly displayed in men. Histrionic personality disorder is excessive emotionality and attention seeking, usually depicted by inappropriate sexual or seductive behavior. Again, most people with HPD are women. HPD is characterized by a long-standing pattern of attention-seeking behavior. It correlates with extreme emotionality. People with it want to be the center of attention in any group and feel uncomfortable when they are not. And they have difficulty when people aren't focusing exclusively on them. So it's essentially just attention whore personality disorder. As if that helps you remember it. We don't call women that. Narcissistic personality disorder, right? This is we hear a lot about this in fiction, especially because Trump is a narcissist. Um, yeah, a little bit of politics there. Anyway, narcissistic personality disorder. It is a grandiose sense of self-importance and a need for constant admiration with a lack of empathy for others. First of all, narcissists will typically exhibit black and white treatment, as I talked about, whereas BPD is black and white thinking. Narcissism is more black and white treatment, where even unconsciously, if they need something from you, they'll treat you like the best person in the world. Oppositionally, as soon as they've gotten that, you'll be absolutely and entirely tossed aside. For some people, it's part of a superiority complex, and for some people, it's done to compensate for things. Either way, narcissists can be like vampires, always hunting for someone to meet their needs, filling their emptiness by treating that person like they're at the top of the world until they get what they want. And what do they want? They want someone to appreciate them for how great they are in whatever area they decide they need approval for, whether that's like sex, music, taste, whatever it may be. Henceforth, they establish a facade. Uh, um, yeah. You know, uh, they essentially establish this need um, uh, in their victims before casting them aside. Um, yeah. Um, yeah, they, sorry, I was just rereading what I wrote. Yep, essentially black and white treatment. They treat you like a god until they don't need you anymore, and they treat you like shit, and what they need is for you to approve of them and whatever they think. Essentially, they establish a facade based around providing you um, with the middle sections of Maslow's hierarchy of needs, that being for esteem and love and relationships in their victim before casting them aside. Yeah, sorry, just had to edit that. Diagnosing narcissistic personality disorder, right? It's indicated by 5 or more of the following traits: exaggerating your own importance, preoccupied with fancies of success, power, beauty, whatever it may be, believing you are special and can only be understood by other special people, requiring constant attention, unreasonable expectations of favorable treatment, taking advantage of others to reach their goals, disregarding the feeling of others, is often envious of others or believes other people are envious of him or her, and shows arrogant behaviors and attitudes. Most people with NPD are male, just like women with histrionic personality disorder, though women can be diagnosed with narcissism as well, and men with histrionic disorder. Um, yeah. Compensatory narcissism. Let's talk about that. It's not always something that's, based out of a superiority complex. Where did I write that? Yeah. There's normal narcissism, which can be based on a superiority complex, grandiose sense of self. Compensatory narcissism uh, are people that exhibit reaction formation, where to compensate for past hurts or childhood emotional wounds, they create an illusion of superiority. Again, reaction formation isn't specifically just the phenomenon of, something you think and then projecting the opposite. It can also be something that you feel or a trauma and projecting the opposite. They're not only driven by enhancements to their self-esteem, As compensatory narcissism is rooted in the feeling of inferiority and inflating self-importance as a reaction to feelings of inadequacy. They appear great on the outside, but are doubt-ridden, empty, jealous, and greatly struggling on the inside. Narcissists aren't always putting up a facade. That's an important thing to note. Sometimes they are truly successful, just like Trump, but they still hold narcissistic traits with regards to how they present themselves to people in order to exploit relationships, dynamics, whatever it may be. Right? In that case, it's all part of a superiority complex. Upbringing and the linking of upbringing to what is happening. The linking of your upbringing and narcissism. Your upbringing can cause narcissism. In a situation where two children are raised and one is clearly the favorite, one kid may develop narcissism as part of a superiority complex, while on the other hand, the other one might develop it out of compensation. Right? There are these different roots of it. Let's look at narcissism in relationships. Narcissism, due to providing inflated confidence, especially when mixed with legitimate individual success, is correlated with incredibly high short-term relationship success rates for men and for women. People with narcissism typically have the traits that women want in relationships. They score high in attractiveness scales and yada, yada, yada. They report more success in short-term mating and promiscuity. However, in long-term relationships, research has shown that narcissism is related to a series of problems. Besides their lack of interest in forming close relationships, narcissists can be more selfish, perceive their partners in a less positive light over time, get bored easily, whatever it may be. They also report higher rates of divorce and cheating, whatever it may be. It's also important to note, generally, narcissists typically groom their victims. They learn how to break people down, slowly get their way, devaluate people, and start controlling people, and it's all intentional. Sorry, it's not all intentional. Cluster C. These are anxious and afraid. So just to recap, we've gone through cluster B, which is characterized by dramatic, emotional, or erratic behaviors. We went through antisocial, borderline, histrionic, and narcissistic personality disorder. We went through cluster A personality disorders, right? Autoeccentric. We went through paranoia, schizoid, schizotypal. And now, finally, we have cluster C being anxious or fearful personality disorders. Here we're looking at avoidant personality disorder, first and foremost. Avoidant personality disorders essentially show avoidance of interpersonal contact because of risk of rejection, fear of criticism, and feelings of inadequacy in social situations. It inhibits development of intimate relationships despite wanting them because of fear of being ridiculed and ashamed. Again, the main difference between this and schizotypal is that schizoid does not care about criticism. APD does. Schizoid doesn't really care about having a partner, but APD does. They're just really scared of rejection. That's APD for you. Dependent personality disorder. Essentially, it is the need for others to take responsibility for major areas of life, or feeling a discomfort or helplessness without support from other people. So pretty self-explanatory. Again, dependent personality disorder. Then we have OCPD. Don't confuse this with OCD. OCPD is a personality disorder. OCD is an anxiety disorder, and we're going to get into this. OCPD, obsessive-compulsive personality disorder, is characterized by perfectionistic nature, over-conscientiousness, indecisiveness, stiffness, and the unable to express affection. These are all different symptoms of OCPD. Remember, again, OCPD is not OCD. OCD is more anxiety and marked by intrusive thoughts regarding obsessions, essentially demanding that they engage with obsessive compulsion until relief, and this is usually exhibited in repeat behaviors done in order to reduce anxiety. OCPD, on the other hand, is a personality disorder about perfectionism and how it can be so pervasive that it dictates all of your actions and takes over your life. People with OCPD are preoccupied with things like rules, lists, and other which can result in missing the major objective of an activity. although it it results in having extreme dedication to work. At the same time, they can miss deadlines because of how focused they are on the minutia, and they'll have pretty much no leisure time as well because of that work commitment. Yeah. In OCPD, unlike OCD, behaviors are egocentric. In OCPD, it's also important to note, and we'll get into this, but OCPD, the person feels like what they have is perfectly fine. They don't realize that it's an issue. OCD, they do realize that it is an issue. This is just a quick summary of personality disorders again. Borderline is instability in personal relationships, self-image effects, and marked impulsivity. Antisocial personality disorder is disregard or violation of the rights of others. Histrionic is excessive emotionality and attention-seeking. Narcissism, grandiosity, need for admiration, lack of empathy. Avoidant, right? Social inhibition, feelings of inadequacy, hypersensitivity. Dependent personality disorder, submission and clinging behavior related to an excessive need to be taken care of. Schizoid, detachment from social relationships and a restricted range of emotions. Paranoid, distrust and suspiciousness in others, motivating, whose motives are interpreted as malevolent and obsessive compulsive, right? This is disorder preoccupied with orderliness, perfectionism, and control. A little note here. Now that we've gone through our clusters A, B, and C, or uneccentric, dramatic, emotional, erratic, and anxious and fearful, there's a correlation between attachment styles that we talked about way back and personality disorders. Essentially, insecure avoidant attachment and the childhood behavior exhibited within them correlate with schizoid personality disorder and its symptoms. Insecure ambivalent attachment and the childhood behaviors exhibited within them correlate with borderline personality disorder, and insecure, disorganized attachment and the childhood behavior exhibited within them correlate with antisocial personality disorder. So it's not saying that everyone with these attachment styles have these disorders, but there's a correlation with the symptoms and the life track. Yeah. Okay, so those are all in the categorical approach to personality disorders. Let's get into the dimensional approach to psychological disorders. Let's just cut that down. Very nice. Okay. Essentially, the dimensional approach is essentially we break groupings of symptoms down into 5 categories, just like we looked at before, and we'd grade people on each factor. It's important to note here, as we look, psychoticism doesn't mean what Asyncs used it as from the previous chapter. Instead, it kind of just means schizo-esque. It doesn't specifically mean psychotic, as we looked at it before with Asyncs' theory of personality, right? That big wheel that we looked at, where high psychoticism is low constraint, right? With high psychoticism being characterized by things like extroversion, like all these things. Again, it's hard to use the dimensional approach. It's hard to use it to get a proper diagnosis, as different disorders can overlap with different sections of the dimensional approach. But it is a theory for a reason. Some people must use it, so can't really shit on it too hard. Anxiety disorders, right? Let's get into these. So this is another little meat and potatoes section. Most of the ones that we're going to be looking at here are, so first, general characteristics of anxiety disorders are things, anxiety disorders are marked by psychological arousal, feeling of tension, intense apprehension without apparent reason. We'll be looking at general anxiety disorders, panic disorders, phobia, and OCD. So, anxiety versus fear. Anxiety is diffuse, vague, and it's an unpleasant feeling that something bad will happen, and it lasts for a long time. Fear is intense, and it's the sudden increase in terror in the face of perceived danger. It's very short-lived, right? In fear, the threat that you have is clear. In anxiety, you don't really know what the threat is. You're concerned with the future, while with fear, you're concerned with the present. Anxiety is less intense as opposed to fear being more. And the form, anxiety can depict itself in things like a general anxiety disorder, which we'll talk about, while fear kind of looks more like a panic disorder and a phobia, which we'll talk about as well. So, types of anxiety disorders. 1. Generalized anxiety disorder, or GAD. Again, it is a form of anxiety characterized by excessive uncontrollable worry about various topics. It usually persists for 6 months, often without obvious cause. The threat and danger are imaginary, though. That's important to know. Usually it follows as having constant worry, leading to sleep issues, leading to that original worry growing, leading to being constantly tense, leading to being easily started, leading to constant headaches due to hyperfixation, and the cycle more or less repeats, right? Kind of like an endless cycle of these symptoms here. General anxiety. Again, excessive, uncontrollable worry about various topics. Panic disorders here. Panic disorders are an anxiety disorder in which someone suffers unexpected severe panic attacks that start with a feeling of intense apprehension, fear, terror, whatever it may be. The indicators of panic disorders are similar to those of generalized anxiety disorders, except that they are greatly magnified and usually have a sudden onset, right, because they're more due to fear. Panic disorders can usually occur with agoraphobia, which is a type of anxiety disorder involving fearing and subsequently avoiding places that may cause you the feeling of being trapped or helpless. People will usually avoid fear or avoid public places, due to the fear of having another panic attack. We'll get into agoraphobia later, though. But again, people with panic disorders usually avoid these public places due to the fear of getting another panic attack, and that is agoraphobia. Its clinical features are a discrete period of intense fear or discomfort in which 4 or more of the following symptoms developed abruptly and reached a peak within 10 minutes. Palpitations, pounding heart, accelerated heart rate, sweating, trembling, sensations of shortness of breath, feeling of choking, chest pain, nausea, dizziness, derealization, fear of losing control, fear of dying, paresthesia, which is like numbness or tingling sensations, and chills and hot flushes, right? These are our panic disorder symptoms. Phobias. Phobia is a persistent and irrational fear of an object, activity, or situation that is excessive and unreasonable given the reality of the threat. There are 2 major categories. These are specific and social phobias. So specific are excessive fear in response to specific, not random objects or solutions, right? Things like animals, natural environments, blood injection injury types, right? Like blood, needles, open wounds, and situational types, right? Being alone at home, flying, closed spaces, whatever it may be. Then we have social phobias, right? So that was our specific phobia. Now we have social phobias. Social phobias are essentially a social anxiety disorder. It is an intense, persistent, irrational fear arising in anticipation of public situations in which you can be observed and be subsequently humiliated, potentially. These situations include meeting strangers, giving speeches, whatever it may be. The symptoms include things like blushing, sweating, shaking, and avoiding people. People with this social phobia are typically frightened by the mere thought of having to interact with people and are always afraid they're going to say something stupid. They typically overthink how people think of them, right? So again, phobias, we have specific phobias and social phobias. Most Americans, for a fun little break, are scared of death and public speaking, right? 65 to 70%. The next highest is spiders, with 30% being scared. So that gives us our general anxiety disorder, our panic disorders, our phobias, and now we have agoraphobia, right? We mentioned that. Agoraphobia, just a light touch, is a fear of situational type of specific phobias, right? It is a form of a situational type of specific phobias. It is the fear of public spaces where escape might be difficult, often resulting in avoidance of travel, crowds, being alone. We are just going to do this here. Add this in. Sweet. Let's cook. Sorry, I removed agoraphobia from being its own little section and just moved it under the situational types since we are talking about that already. Yeah, let's keep cooking. So now we have gone through our general anxiety disorders, our panic disorders, our phobias, right? Our types of anxiety disorders. Our personality disorders, schizophrenia and positive and negative symptoms, our mood disorders, understanding the approach to psychological disorders, and understanding psychological disorders. Now, we have obsessive compulsive and related disorders, right? OCPD and OCD. That is what we are looking at here. So, obsessions are thoughts, images, or impulses that recur or persist despite a person's efforts to suppress them, right? We're looking at OCD here, not OCPD. So, again, obsessions, thoughts, images, impulses that are recurring despite a person's efforts to suppress them. Compulsions are the repetitive and purposeful acts performed according to certain rules or in a ritualized manner in response to an obsession. A compulsive behavior serves to reduce the anxiety produced by a form of depression. So the OCD cycle typically follows as an obsession happening, right? A fear or an intrusive thought, followed by anxiety, which is a need to act, which leads to a compulsion, which is the acting or ritual to reduce anxiety, leading to relief, which is temporary, which then leads to obsession again, right? And it repeats. To compare obsessions and their following compulsions, we can look at things like a fear of contamination, which is an obsession leading to an intense cleaning ritual, which would be the compulsion. OCD can also be an overuse of an undoing of thought, which is a defense mechanism. For example, if you have sexual or violent intrusive thoughts, you will try to think away from that thing and do the opposite, right? That's another form of technically like an obsession and a compulsion. But yeah. So again, OCPD versus OCD. OCD is ego dystonic, meaning, people recognize that there's an inconsistency in who they want to be and who they are. They recognize the problem. OCPD is not ego dystonic. It is ego syntonic, meaning these people are in tune with themselves. They don't really think anything's wrong with them. They don't really think it's a problem. OCPD people are driven by perfectionism and the need to control. OCD people are driven by anxiety, leading to compulsion. OCD people have rituals to reduce obsessions. OCPD people have rigid lifestyles based on control. OCPD people only seek treatment in the face of threatened loss, like being fired. And OCD people typically try to treat problems as soon as they're aware of them, right? Almost done here. We have trauma and dissociation. This is a big section here, right? So first and foremost, post-traumatic stress disorder, right? PTSD results from exposure to traumatic events, leading to a re-experiencing of those traumatic events. These symptoms include intrusive memories, flashbacks, avoidance of triggers, hyperarousal, numbing, or dissociation. We will talk about that, right? We'll talk about subclasses within PTSD with dissociative specifiers. But PTSD is usually a development in response to things like rape, life-threatening events, severe injury, and natural disasters. The trigger for it is 100% environmental. What had we looked at before, just so I can draw that comparison? Where was it? Yes. PTSD, as I said, it is a discrete entity. It is not a spectrum disorder where you have one thing leading to another, which is PTSD, and it's not something that grows and develops. It's something that you are born with. It's not something that you are born with. It is something that is in response to an environmental factor of some kind. Again, when it comes to schizophrenia, you can be born with it. It is a multitude of triggers. Even though the experience and the impact on the body of the two conditions is similar, their triggers are completely different. In some PTSD individuals, they will lose the ability to specifically remember the traumatizing event. This is called paratraumatic dissociation. Essentially, the extreme terror of the event can cause a part of the brain to stop functioning, causing a lack of conscious awareness in that moment. Through time and triggers, these memories can be recovered. It isn't always the victim that experiences PTSD, though. Sometimes it's the perpetrator. So these triggers in this recovery method can look a lot different for all kinds of people. But yeah, it's important to note, again, sometimes it's the perpetrator with PTSD, from having been forced to do something, which is like something that we saw in Milgram's study, for example. PTSD can trigger agoraphobia and other disorders and other different ego defenses, right? PTSD symptoms can last for a month or longer and cause significant impairment. And PTSD, funnily enough, used to be considered an anxiety disorder as opposed to a trauma disorder, no longer. So as we discussed, PTSD dissociative specifiers. So within PTSD, there are specifiers. Essentially, they're subclasses. Here we're looking at the subclass of PTSD with dissociative symptoms. So essentially, we specify whether with dissociative symptoms, the individual meets PTSD criteria and, in response to the stressor, experiences persistent and recurrent symptoms of either of the following. 1. Does the person have depersonalization, right? Depersonalized PTSD. This is persistent or recurring experiences of feeling detached from and as if you were outside of your body and your mental processes. For example, it's the feeling as though you're in a dream, feeling a sense of unreality or self or body, feeling like time is moving slowly. And 2, another dissociative specifier is derealization. This is persistent and recurrent experiences of unreality of surroundings, right? Thinking the world around you is unreal, dreamlike, distant, or distorted. To be able to use these subtypes, remember it's important that the symptoms must not be attributable to substances or other medical conditions. Yes. Now that we've talked about PTSD and PTSD with dissociative specifiers, let's actually talk about dissociative disorders. So essentially dissociative disorders, they are disturbances in the integration of identity, memory, or consciousness. People suffering from them feel that the self is inconsistent in many aspects, the self is discontinuous, and some important personal experiences are being forgotten. There are different kinds of dissociative disorders. We'll talk about these. There's dissociative amnesia, dissociative fugue, or fugue, depending on how you say it, and DID point blank. So, just to go through these. Dissociative amnesia. This is the inability to recall personal information, such as experiences, that of which inability is caused by psychological factors without any physical injury. So, for example, it's caused by an alteration of consciousness. It's not caused by being banged on the head. If someone has dissociative amnesia, they don't necessarily have dissociative fugue or DID. And we'll talk about this, if you have fugue, you do have DID and dissociative amnesia. So what is dissociative fugue? This is an amnesic state involving the unexpected departure from one's customary surroundings, the assumption of a new alter identity, and an inability to recall or remember your previous identity. So it's kind of this point where you just blink, you drop out of your surroundings, and now you have a new alter identity, and you have the inability to recall who you were before. This state usually ends when the host identity person abruptly wakes up to find him or herself in an unknown place. Again, this sounds a lot like DID, but we'll explain why it's part of DID, not DID entirely. But again, if you have this, by definition, you have DID and dissociative amnesia. DID. So DID is a disorder in which dissociative identity disorder is a disorder in which two or more distinct entities or alters with unique behaviors, voices, and memories exist within the same individual. This was formerly known as multiple personality disorder. Now it is not. Each emerging personality contrasts in some way with the original self. For example, the new is outgoing and the old is shy. The hosts with DID will often try to separate themselves from the alters that represent their undesirable selves, right? We talked about that with personality. With some alters being specifically used to, for example, release pent-up undesirable emotions such as intense anger. We talked about that idea too in psychic energy, right? And the id coming out. Each alter essentially has a role to play. Each identity can vary in name, gender, behavior, voice preference, allergies, handedness, brain activity, accent, language, whatever it may be. Literally, for all intents and purposes, they are a different person. Each personality has a unique role to play in helping the person, the host, deal with a difficult life situation. Each alter can sometimes exist mentally within a person at the same time, to the point where the host can communicate with their alters, but this is not always the case. Switching from the host to an alter, that of which is usually triggered by something in an environment related to the alter, can sometimes be noticeable and sometimes not. According to the victims, or the people with this story, it feels like passing out as your host mind goes unconscious, which is what the dissociative fugue part is, but in reality, it can look like a blink and suddenly you're an alter. When the host returns, they won't remember what happened as if they'd passed out, which is the dissociative amnesia part of this. So again, with the ID, you have both fugue and amnesia. So let's break this down more. Essentially, what is the root of this, right? There's evidence linking DID to severe childhood trauma, such as abuse and neglect. The patient develops DID in an attempt to disown a part of themselves that is too painful to live with. This shows that at its core, DID is a defense mechanism. For example, we watched a video in class, and the host with DID has 8 alters. One of them believes that they're a vampire from the 1920s, and the host believes that this identity was formed to separate herself from her family, as someone in the 20s wouldn't have been awake around or even related to her family, as they're a vampire from the 20s. One experience with trauma can lead to PTSD, but repetitive experience with that trauma can potentially lead to DID, especially in early childhood. That is the root, again, this early childhood. The function, right? How do we break it down? How does it really work? Essentially, a person with DID has 2 or more memory systems. Let's call them A and B. Memory A contains information that forms the identity of the host personality. Memory B, which split off from A, contains that information which system A was unwilling or unable to integrate. The concept of it. Essentially, we're all born with different parts of our personality, but much of what our personalities become and our identities that form as we go through life aren't formed or solidified at birth. As we go through life, who we are is shaped, and all our parts of our personality form to become one cohesive identity. When it comes to DID, severe childhood trauma can form walls, essentially, between parts of our personality, those of which are intended to keep traumatic memories separate from everyday life. This walling can continue as we age, depending on the stimuli we experience. Additionally, amnesia is sometimes formed as a result of the walling itself. As a result, a lot of different parts may not even know about each other or have the condition itself. They might not know that they have the condition. Right? The timing of these separations can also mean that different parts have different memories, different ages, different feelings, different names, whatever it may be. The theoretical view on DID is essentially, it's an extreme version of normal identity fluctuation. The idea comes from Dr. Jekyll and Mr. Hyde. Essentially, we all contain Jekyll and Hyde in us, right? They're all situations determining which identity comes out, but people with DID are just a more extreme case of this. That is DID in a nutshell. An additional concept here, sex differences in disorders. Prevalence and presentation disorders may differ by gender, age, especially for mood, anxiety, and personality disorders. Right. Men and women aren't, they're not equally as likely to get different disorders here. Yeah. That is our lecture on psychological disorders, again, we looked at brief talk about sex differences, but most importantly, we talked about dissociative disorders, PTSD. We talked about trauma and dissociation. Through that, we looked at OCPD and OCD, and we compared them. We looked at some anxiety disorders, right? Like phobias, panic disorder, generalized anxiety disorder, anxiety and fear. We looked at personality disorders, right? Different clusters. Cluster A being uneccentric, cluster B being dramatic and emotional and erratic, and cluster C being anxious or fearful. We talked about the dimensional approach to psychological disorders and the categorical approach, with the categorical being the clusters and dimensional being kind of like a wheel with different sections, these 5 sections. A little bit of a correlation between attachment styles and personality disorders. We talked about schizophrenia and positive and negative symptoms in psychological disorders. We talked about mood disorders, right? Unipolar versus bipolar. We talked about understanding the approach to psychological disorders through the dimensional approach, which is iffy, and the categorical approach, which we look at now. And we just generally define psychological disorders. That was our final lecture. I will be taking further levels of psych. It is my major, so feel free to come back 4 months from now and check it out.